the month of March. It is Colon Cancer Awareness Month, and so we are hosting a show today to bring education to our community. My name is Denise Mananis. I am your host for this event today. But before we begin, I would like to acknowledge do all the production to bring these shows to us live, and so I just want to extend my appreciation and thanks to them. Also, I would like to acknowledge our original partners on these educational programs in our community. The Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library. Those are our original partners, but also our new partners, the Ashling Irish Community and Cultural Center, the Department of Veterans Services from the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, the Bronxville Community Center, the City of Yonkers, Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathway to Success. For those of you who are watching us live, our live stream on YouTube, please post your questions if you have any in the comments section, and we will do our best to answer them after the interview. And now I would like to introduce our guest today, Dr. Mohamad Erfani, gastroenterologist. Welcome. And let me tell you all a little bit about Dr. Erfani. Dr. Erfani is a board-certified gastroenterologist with almost 2 decades of experience in the field. He has a medical degree from Iran University of Medical Sciences. Dr. Erfani pursued advanced training and education in internal medicine at New York Medical College, culminating in a fellowship in gastroenterology and nutrition at Montefiore Medical Center. Dr. Erfani is dedicated to both patient care and education, having taught at Mercy College and New York Medical College. He has received numerous honors and awards, including the Peer-to-Peer Excellence in Medicine Award from the Bronx County Medical Society in recognition of his clinical expertise. He has contributed to gastroenterology research with numerous publications and presentations at national conferences. He is also a passionate volunteer and athlete with notable accomplishments in marathons and triathlons. That's why you look. Commitment to serving our community and ongoing contributions to the field of gastroenterology. So we are thrilled to announce that Dr. Erfani has recently joined the St. John's Medical Group, and we are so happy to have him as our guest today on Riverside Talk. So welcome.
Thank you for having me.
Of course.
Thank you for the introduction.
Of course. So let's get right into our conversation. So let's start with, there's been a lot of people in the press recently. We are hearing a lot about celebrities. For example, Chadwick Boseman, who did pass away from colon cancer, James Vanderbeek, who just came out publicly talking about his diagnosis, and Sharon Osbourne, to just name a few. So many people are being affected by colon cancer right here in our community. So let's start with who's at risk for getting colon cancer, and the second part of that.
First, thank you for having me. So for the first part of the question is, literally everyone is at the risk of colon cancer, and the risk of colon cancer, the main risk factor for colon cancer is age. As we get older, the risk for colon cancer goes up, especially, and the risk for colon cancer pretty much is with us, and as we get older, it just increases.
Okay.
In terms of the incidence of colon cancer, the colon cancer, the incidence and mortality for colon cancer in the last couple of years has gone up, has been down, especially in individuals age 50 and older. But unfortunately, meanwhile, as we see, and probably thanks to our screening for individuals 50 and older.
Right.
But at the same time, we see that the risk for incidence of colon cancer and death from colon cancer has gone up in individuals 50 and younger.
Okay, so that just brings me to the next point, which is that I know that people who are younger are being diagnosed with colon cancer, and so the screening, most everyone who goes to their primary care physician regularly, they get you're 50, you got to go to the GI, have your colonoscopy. But now I understand that rule or that recommendation has changed. Have the new recommendations come out?
Correct. For the same reason that as we looked at the data, we noticed that by aggressive and being updating individuals with their screening for colon cancer, we can decrease the rate of incidence as well as mortality of colon cancer in older individuals. And for the same reason, that's why the recommendation, and as we saw the incidence and mortality of colon cancer in younger individuals is going up, for the same reason, the new recommendation now used to be that they start screening colonoscopy for average risk patients at age 50, and now the new recommendation is to start screening for colon cancer at age 45,
Oh,
not
so-
age 50. So we are now, the recommendation is to be starting at age 45,
45.
and this is specifically for average risk patients. We are not talking about patients that if they have other risk factors, and those individuals we consider high risk for colon cancer, and those individuals may need to start screening sooner.
Okay, so just average risk, now it's 45, but why is it starting to occur earlier in people? Is it our environment? Is it our diet? Is it lack of exercise? Is it, wait, it's all of us, right?
Yeah, I think
Yeah.
that you answered the question. You
Okay.
answered the question. That's correct. The reason for it is, to be exact, is unknown, but you're right. They're attributing the risk of colon cancer that is getting more in they call it early onset age of colorectal cancer. One of the reasons probably is the lifestyle modification that we have in terms of sedentary lifestyle or urban lifestyle, or in terms of obesity epidemics, or there are many risk factors that they're thinking of. But yeah, you mentioned that's correct.
So
probably that's the
diet
reason.
is one of that's particularly interesting to me. Are there, obviously, there's an awful lot of press now too about our food supply, what's in our food. Do you think anything down that line is playing into it? Or is it just the kind of diet that most Americans have?
In terms of diet and colon cancer risk, there are many studies, but in general, the general meat may decreases the risk of colon cancer. So in limiting the red meat and processed meat, as well as in terms of alcohol consumption, if the moderate alcohol consumption, excessive alcohol consumption is related to colon cancer, as well as the smoking. And there are
Okay.
some relation between high fiber diets and as well as diet high in calcium and dairy products may be preventative in terms of the colon cancer.
All right. So those are interesting words you used about alcohol consumption, and I think this is true about the other food things that you were talking about. But excessive, immoderate, what does that mean in terms of alcohol consumption? Because we seem to have younger people in this country who, when I was growing up, didn't drink quite as much as I see the young people now drinking. Is that playing a role?
It could be play a role. In terms of what recommending as a physician to the patient is that if you don't drink alcohol, do not start.
Oh,
So
That's
if you're
a
not
good one.
drinking, if you're not starting, just
okay.
But if you are drinking alcohol, the recommendation is have a moderate alcohol consumption.
All right.
So yeah, that might be
Moderate
one of
is 1 drink a day, 2 max?
Yes.
Okay.
You said, for example, 1 glass of wine a day for
With
per
a
day.
meal.
With the meal, yeah, that would
Okay.
be the case.
All right. I feel better about that.
Okay.
Okay. All right. So is there a difference between of the same? Are you seeing the same numbers?
The incidence of the colon cancer in the last decade or so has gone up by 2.4%, as well as the cancer mortality, which is almost at 1% in younger individuals. And it involves both men and women, and of course, men are more at risk of colon cancer. But again, it doesn't mean that there is no protection in terms of colon cancer. So,
Okay.
in general, the recommendation of age 45 goes for both male and female, although you might see a little bit more in the male patients.
Okay. So, all right. I want to talk a little bit about the screenings, and many people have some fear when it comes to the kinds of screenings that are available, because I think it's an unknown to them. The first one I want to talk about is Cologuard. Can you explain what that is and who qualifies for that, and why is that effective?
In terms of the tests available for colon cancer screening, in general, we divide them in two categories. There are tests that is a stool-based test that for colon cancer screening, and the other ones are visual tests that basically we look at the colon to see if there is any precancerous lesion or cancer, or no, we just do by a stool test. So in terms of Cologuard that you mentioned, which is a multi-targeted stool DNA test, that is the only one available in the United States, Cologuard. It's a test that looks at basically if there is any hidden blood in the stool, as well as or if any abnormal DNAs, that they detect them in the stool, and then based on that they can predict that if the patient or individual has any precancerous or any cancer lesion in the colon. And so in this way they can detect the
So it
lesions
does,
much
based on
earlier.
the DNA, it can detect presence.
Correct. So the test, basically the way it is performed is that they send a kit for the patient, and the patients send their stool
sample.
samples for the laboratory, and they look at when they study analysis of the stool, they look at not only the hidden blood, but also we know that the cancer cells or precancer cells, they shed a little bit of their DNAs in the stool, and then those DNAs, for example, we call it hypermethylated DNAs. They are abnormal DNAs that we can detect to see if there is of those abnormal DNAs that is shedding from those precancerous or cancerous lesion, that we can detect them in the stool. And if that is positive, then they recommend the patient to promptly to get the colonoscopy.
Okay, so who qualifies for that test?
So the screening for colon cancer, majority of these tests that we do, stool-based or visual tests, are covered by insurance. So everybody age above 45 and older, they are eligible to get the stool-based test, including Cologuard, or the visual tests, including colonoscopy, sigmoidoscopy as well.
All right, so let's talk about colonoscopy and sigmoidoscopy, because those are actually a little bit invasive. But I think that's where some people have some nerves about that process. So the difference between sigmoidoscopy and a colonoscopy is what?
So colonoscopy is more comprehensive test. Basically, both of them, it's a test that the patients needs to get some sort of preparation in terms of cleaning the colon and intestine. They need to take some sort of preparation in terms of cleaning the intestine, laxatives and purgatives. And when they clean the colon and intestine, there is a scope, there's a camera and light on it, and they go from the rectum. In terms of colonoscopy, the examination of the colon is complete from the rectum all the way to the end of the colon, which is the cecum. And in terms of sigmoidoscopy, is the same procedure, but is way limited. Only we are looking mostly on the left side of the colon in the first 30 or 40.
So it doesn't go all the way around the large intestine, the sigmoidoscopy. So why would you do that and not just do the colonoscopy if the prep is the same? What would be the point?
So the preparation for sigmoidoscopy is less, and also for sigmoidoscopy there is no need for sedation most of the time. Sigmoidoscopy, but colonoscopy, majority of the time we need a sedation. So maybe that's a factor that is been so if one of the factors that if the patients, we know the gold standard for the colonoscopy, for the screening for colon cancer
is colonoscopy. Okay. So this is going to sound funny, I think, but we are taking pictures on Mars. Why is the prep for colonoscopy so difficult to make it more palatable for people to actually take it?
There are lots of new products available.
Really? Do tell.
Yeah, there are lots of new products available in the market that they have a better taste, and especially in terms of the volume, because there are two issues with the patient when they want to take the preparation. One is the paste, as you mentioned, that you're working on that, and there are different type of flavors.
Do they really taste like that?
I, yeah,
Yeah,
kind
okay,
of. And
okay.
then the other part of it is the volume of the liquid that they should take. So
Yeah.
I think that the new products work on both. So there are preparation out there right now that they do way taste better than what we used to have, like a big gallon of solutions that we used to take. And also in terms of the volume, now there are solutions that you only take like just 16 ounces, and then after that you just take a couple of another 16 ounces or 32 ounces of water. So they're working on that as much. But at the end of the day, the issue is that really we have to clean the intestine, and
Right.
it's something that has to be done.
All right.
But yes, there are much improvement.
So
in
I'm
that
feeling
function.
better about that. Now, that's the same prep that you would do for the sigmoidoscopy, but you don't need to do that for the Cologuard, obviously.
So, yes. So a stool-based test regarding if it's a Cologuard, which is a multi-targeted stool DNA test, or if it's a guaiac-based fecal occult blood test, or if it's a FIT test, we call it fecal immunochemical test. All these tests that are stool-based, there is no need for preparation, there is no need for sedation, and it can be done at home. So it has all the ease of that. There is no need to lose the day at work, and
Great.
they're non-invasive tests. So that's the advantage of it. They might not be as the same. They don't have the same accuracy probably as a colonoscopy, but they have the benefit of being non-invasive and less disruptive in terms of the work and work schedules. But we have to remember all these tests that we do are like a two-step test. So because if any of those tests are positive, then the patient
still
needs
have
to
to
be
come
prompted
in
to
and-
get the colonoscopy
And,
done.
okay.
This test is like a two-step test. So if as far as it's negative, you can keep doing it, especially for the FIT test and guaiac tests every year,
Right.
and for a Cologuard or DNA tests every 3 years.
Okay, so, but I want to go back into the frequency of these tests, but, one thing we didn't talk about earlier is that for people of average risk, we were speaking about, but the people who have higher risk, and what do you consider higher risk to be? Is it a genetic component? What is it?
Correct. So the recommendation is every individual, especially in late 20s and 30s, to discuss with their doctors, especially if one of the risk factors for colon cancer is hereditary genetic syndromes, that they may affect, if there is such a hereditary genetic syndromes in the family, or the personal history of such a syndromes, they may need to get screened way sooner than age 45.
So let's say it's your great uncle versus your grandfather. Are they equally put you at risk?
The family tree, you have to look at the whole picture. But
Okay.
if you just specifically you're mentioning just one second-degree relative, it is still might increase the chance of colon cancer, but it doesn't change the recommendation for colon cancer. Still considered be as average risk. But if you have one or you have two or more, for example, second-degree relative, or you have a first-degree relative, which is parents, siblings, child, the first-degree relatives, if they have a colon cancer or they have an advanced pre-cancerous lesions in their colon, that story of colon cancer or personal
First-degree relatives.
first degree, both personal history. If somebody
Okay.
has a history of colon cancer or history of we call it polyps or pre-cancerous lesions,
Okay.
they need to be screened at a different interval. That's a personal history. The second risk factor, if they have a family history, especially in the first degree relative family,
Okay.
if they have history of colon cancer or advanced colon lesions
Right.
or precancerous lesions, they need to be screened. Or multiple second degree relatives, they need to be screened sooner.
Okay.
And the other risk factors could be specific diseases like inflammatory bowel disease, like Crohn's disease, ulcerative colitis. If they have history of radiation to the abdomen or pelvis in the past, as well as I mentioned, if they have any history of hereditary genetic syndromes in the family, those are the type of individuals that they are not average risk for colon cancer, and their recommendation and when they have to get colonoscopy
Is different.
is going to be different. It's going to be sooner, and that they have to discuss with their doctors as well as the gastroenterologist to determine when and how how frequent. Maybe it's not. They might get more frequent and also earlier to be screened for the colon
So
cancer.
one of the big takeaways from today is that even if you're in your 20s and 30s, this is a conversation you should be having with your primary care physician.
Definitely.
Okay.
And that conversation needs to be repeated every couple of years to update their family history, because at this point you might not have any family history, and 3 or 5 years the family history should be updated, and then that discussion should be continuing after 20, 20, and 30 years, and that's something that you have to always be in constantly conversation at least every 3 to 5 years.
Okay. So you're talking about how often people should be getting screened. Can we talk about the accuracy of these tests? So Cologuard, is there a percentage that it doesn't give you the results? I mean, so for me, I'm a skeptic, right? And so when I talk to my physician, I'd rather just go right to the colonoscopy and be done. I don't want to have to do it in 2 parts and wonder in between. You know, that's just preference for me. But is there an inaccuracy in those tests?
So, the question has different folds. I'm going to go in one by each. First of all, I just want to mention and emphasize that the best test for colon cancer screening is the test that the patient is doing it. So,
Okay.
regardless
fair.
So regardless of accuracy and sensitivity and specificity, we can go through that. But the most important thing is that if a patient's willing and doing one specific test rather than doing none of them,
Yeah.
that's the best approach. So I always say that the best test for screening colon cancer is the test that patient is willing to do it. Having said that,
Okay.
as we know, the gold standard for colon cancer screening is colonoscopy with accuracy of 95%. So in terms of Cologuard you mentioned, the accuracy of the Cologuard test is not far below colonoscopy. It's like around north of 90%. It's like a 92% around that average. But again, there's a highly accurate test.
Okay. And better to do that than
Not
nothing.
as accurate as colonoscopy, but yes,
Okay.
exactly. But it is accurate test. Those tests that are available right now in both the FIT test as well as the fecal occult blood test as well as the Cologuard, they the FIT, in terms of FIT test and fecal 70%, 75%. But the important is that in all of these tests they have the number of colon cancer deaths that they prevent, pretty much they are going far enough to be accepted as an option for colon cancer
Okay.
screening. But the accuracy of a Cologuard is around 92%.
When you do the test, how long is the test, by the way?
The procedure itself usually takes around 20 minutes to 40 minutes, half an hour probably. It depends on what we found and how
Right.
easy or difficult the colonoscopy is going to be. But the whole process, by the time you come to the center or to the hospital to get the procedures done and go home, maybe it takes a couple of hours. So that's one of the disadvantages.
But the
of it.
actual test where you're sedated
Maybe
is
around half an hour,
half
20
an hour,
minutes.
20 minutes, okay. So you find a polyp. So can you explain what that is and what do you do when you see one?
So one of the benefit of colonoscopy, besides that is the most accurate test, is not that like the other tests, like a fecal based test. That's not only diagnostic but also therapeutic. At the same time that you see the polyp, you can right there and there you see the polyp and you can take it off and you cut the polyp. So if we see any lesions that precancerous lesion or any polyps, regardless, we're gonna cut them out. So basically, when the patient finishes the procedure,
They're gone.
either they have no polyps to begin with, or if they had any polyps, we take it out. Now, if there are lesions that they are too big to be cut by the by endoscopy,
Okay.
then usually we mark those. We do biopsy from them to make sure if there is any cancer or not, and also we can mark them for if that's a lesion that need to be done by an advanced endoscopist or sometimes by surgery to be removed. But in general, majority of the polyps when we do the colonoscopy, they are in the range of that can be taken care of during the procedure itself. So colonoscopy is not only screening and early detection and prevention, but also is therapeutic in terms of treating the polyp right then and there.
Okay. So before we talk about treatment, so let's say somebody gets a diagnosis that they do have colon cancer, and I know there's stages of it. I do want to just curable if it's caught early. Is that correct? Is that a fair statement?
That is a fair
So,
statement.
so getting the test, whatever test, and doing it with frequency is very important. So let's talk about the treatment options. And you talked about you're in the colonoscopy and you remove the polyps and then they go out for testing, or you see a lesion and you go in and you have to, you run the biopsy on those. So what happens now? You get a positive diagnosis. What goes next?
So, so just one mention, what you mentioned before answered your question and also to be updated with it. So I have a lot of patients of me come to me and they had a screening colonoscopy in the past, either through the stool-based test or colonoscopy, but they are not updated with it. So they are
So they haven't done it frequently enough.
So one thing is that probably around 40% of Americans, either they haven't had any screening or they
40%?
Yes, so depends of different studies. You say 60 to 70%. They are not either they haven't been screened or they have been screened, but they are not updated with their screening test.
Okay, so they did one 10 years ago, and I'll get around to it again at some point.
So, or yes, or you did a stool study that the doctor said you should do it every year, and the last time they've done it, it was like 3 years ago, 5 years ago. So it's important to not only to get screened for colon cancer, but also when you screen, it's important to be updated on that, especially between age 45 and 75. So it's just screening first time is important, but also being updated with the screening also is important.
So let's talk about that before we go to treatments and other things. So if you start at 45 with a Cologuard or a colonoscopy and they see nothing, what's the next time you should be doing it?
So in terms of the Cologuard or stool test-based test, if they are negative, then you just need to repeat it. In terms of Cologuard, the recommendation is to repeat it every 3 years. So as far as it's negative, you're good. But it's important that if the recommendation is 3 years, you make sure that you get the test done every 3 years.
All right.
And if it's other stool, other than Cologuard, other stool-based tests, usually occult blood and fit tests, they are yearly basis. So they need to be checked. In terms of colonoscopy, if it's normal, the recommendation is to be repeated every 10 years, which is that's another advantage of taking colonoscopy. So you don't need to keep doing it every year or 3 years.
Okay.
So, and if there are polyps during the colonoscopy, the gastroenterologist is going to tell you, depends on how many or what type of polyp or how large they were. They should be done in 3 years, 5 years, or 7 years. That's the recommendation. But if the colonoscopy is negative, it's every 10 years. So I just want to get the emphasis of this, that not only should be screened, but also to be updated with the screening, and that is between age 45 and 75 for sure.
So why at 75 does that fall off the cliff? But what is that?
So the recommendation, it doesn't follow 50 and 75 is recommendation A, between 45 and 50 is recommendation B. So basically 45 and 75 is really highly recommended. Between 75 and 85, the recommendation is not to do it. It's just that you and your doctor need to discuss the risk and benefits. So because as we know, as we get older, there are medical conditions and comorbidities and other medical conditions might change, and
that influences
the making in terms of treatment for the patient. We always say benefits versus harms. So between age 75 and 85, the doctor or gastroenterologist, they have to see if the benefits and the harms, if the benefits more than the harm, then definitely they can continue. And so it's just a case by case basis. Okay. Especially now, if 75 and 85, we are talking about people who've been updated before. So if they haven't had a colonoscopy,
then they should probably
the recommendation
go
is
do that.
probably they get that at least. But if they are updated till age 75, then if they should continue to be updated, that's something that they have to discuss. It's not a no. It's just have to discuss with their gastroenterologists and physicians, and they very well may be to continue.
All right. So treatments obviously are going to vary based on how advanced a cancer that's found is. That's correct?
Correct.
So if you are facing someone across the table, across the desk that has been diagnosed with a stage 1 colon cancer, what would the recommended treatments be?
Depends of the where exactly the cancer is, and as you mentioned, if it's in earlier stage, it's very curable. Usually surgically is curable. Sometimes the cancer is so minimal that we can even resect the tumor by the endoscopy. But majority of them in earlier stage end up having the surgery done,
Okay.
and then if it's really limited to the colon and there is no lymph node involved, sometimes even they don't need for any
Wow.
chemotherapies, and especially if early stage. That's the beauty of the
Of the
this
screening.
So
Okay.
because the 5-year survival rate for a stage 1 colon cancer is north of 90%, 92%.
Wow.
And for a stage 4 is like around 11 to 17%. So that huge gap
That's huge.
gonna tell you how important it is to get screened for
All
colon
right.
cancer.
So maybe or maybe
huge.
not in stage 1, maybe chemo, maybe not.
Maybe depends.
No
of
radiation for patients generally, because that's usually the other trick in the hat.
Usually there is no radiation for
Okay.
colon cancer. In terms of rectal cancers, there might be radiation therapy as a part of the
Later
treatment.
stage,
So,
okay.
but usually, especially if in the earlier stages, they're surgical plus minus chemotherapy, and now we have new generation of immunotherapies as well. That is for the cure of colon cancer. But those are being discussed by the surgeons, by the oncologists, and by gastroenterologists. Like usually, they have a multi-specialty panel of discussing, especially for colon cancer treatment. But yes, I just want to emphasize, if it's earlier stage, it's way easy to treat. Sometimes just surgery alone, plus minus some short period of chemotherapy.
Okay. So for people, so I want to talk about the chemo and the radiation. Now, people my age have heard about cancer diagnoses, and people have had chemotherapy for a long time. It's been one of the main go-tos for all kinds of cancer, and radiation. How have they changed in your practice over the years that you've been recommending your patients to go? Because chemo used to be extremely debilitating, and then I guess in some cases it still can be, depending on the kind of cancer you have. But have you seen a change in how they're?
Yes. So basically, because of the advances in surgical resections, as well as the new chemotherapies, as well as I mentioned, now we run a lot of tests on that tumor cells in terms of what type of genes are expressed or not, and addition of immunotherapy. Yes, the duration and the type of chemotherapies that we use is much more tolerable. But at the end of the day, these are the treatments that patient needs to be done, and that's what is exactly as I mentioned. This is so important to get. First of all, to get screened. So if we can, before getting to cancer, to prevent cancer, and then get this precancerous lesion out, and polyps we call it.
Right.
And if there is any lesion, to be so early that we can resect it, either by endoscopy, with the colonoscopy, or by just surgical resection, and there is no need for chemo and radiation. Although there are some advancement, but it might not be it's still the easiest experience.
Okay, very good. So screening. For those of us who have anxiety about our health and who try and get onto the right schedule, what should someone look for in between those four? Because 10 years is a long time, and for people who have anxiety about things like that, I think you need to be armed with, maybe that's not a good thing to be seeing.
So that's correct. So as I tell my patients when they come in, even they have a normal colonoscopy, and I recommend them, say, listen, your colonoscopy was normal, you need to come back in 10 years for the next colonoscopy. But meanwhile, remember, one of the complications of colonoscopy is a missed polyps or missed cancer. So there is a chance because no test is 100% accurate, regardless of is it Cologuard or colonoscopy or
My
any of those
anxiety
tests.
just went up a little. Okay. that's
So,
good.
but the issue is this. I tell them that listen, you need to be screened in the new symptoms or anything that is you think that is unusual, like any new onset of rectal bleeding or abdominal pain or change in the bowel habit. You've never been constipated before, now you're constipated, or you get diarrhea for no reason, or you get or you're diagnosed with anemia, which is unexplained, or God forbid losing weight, or fatigue, or something that is lack of energy, or something that is unusual in your stomach. You feel different in terms of your digestion. If any of those things that you feel, then you need to come to me, and we may need to get the screen for colon cancer or some sort of test to be done to look into it.
Okay.
So yes, so there is no need to be that much of anxious if you had a good colonoscopy, normal colonoscopy, and the recommendation is 10 years, you should be assured the risk of colon cancer is way down. But again, in between,
You gotta pay
you should be
attention.
vigilant, and then you have to be vigilant. And if there is any new symptoms or something that is unusual, definitely you should go back to your doctor and gastroenterologist and talk with them.
Same things that people are looking for in that time frame would be things they should be looking for even at 45 or 40 in their habits. If something suddenly changes, that's a very important key.
Correct.
Okay. I'm just looking at our questions online, and you've covered the age that we should be having discussions with our primary care starting in the 20s and 30s, especially if there's anyone in the immediate family who has had or is dealing with colon cancer. And then the age recommendation nationally has gone from 50 to 45.
Yes, and Denise, we also have to acknowledge Dr. Zachary DeVore,
Oh.
another gastroenterologist.
We have yes, Dr. Zachary DeVore is our advanced endoscopist in our St. John's Medical Group. So thank you for being with us today.
Exactly.
Yay. All right, any questions?
Do we have any questions from our live audience right now?
No, everything you have asked, I've thought about it, and I'm updated on it.
All right. That's very good. So our audience member asked about just, the fact that we reiterated the age and when it's important to speak to your physician. We have another question back there.
Thank you. Coming right to you.
Thank you. Hi, I'm Eric.
I'm Sally Jesse.
I'm the Director of Medical Operations and Health Equity. I have a question. So my great-grandfather passed away from colon cancer. Yet I still notice some, and it's on the Hispanic side of my family. I notice still some hesitancy with my family members with getting screened. They're 45, but they also, in their lineage, closer than me, have had someone affected by this. My question is twofold. How do I, as an individual, encourage my loved ones to be screened? And then how do you encourage patients to be screened who may be afraid of the procedure or afraid of the results themselves?
In terms of the first part of the question was that in terms of the risk that you mentioned. So a great grandfather, if had a colon cancer, if it's you have, the thing is that you have to get a broad picture of the family history. If that's the only cancer in the family, sometimes we call it that hereditary cancers that might not be exactly colon cancer, but different type of cancer, like endometrial cancer or other cancer that might be related in a bigger picture in terms of hereditary genetic syndromes. And the other issue is that, no, if that's only great-grandfather, still you consider to be average risk. But as I mentioned, you have to have a good picture of exactly all the family history in that regard. In terms of how we encourage patients to get the screening for colonoscopy or for screening for colon cancer, that's a discussion that actually should be between the doctor and the physicians. The patients and the physicians, they need to discuss. One option is that we tell the patient that there are options that they have in terms of if they are in average risk, you have options to get done for the for screening for colon cancer, and it's not just colonoscopy. And they have for colonoscopy, their only concern is, for example, for sedation. So if the anesthesia and sedation part is the problem, so we can address it. Sometimes it's the pain. So depends on what is that exactly make them unease to not do the procedure. It's for if each patient is different. Somebody is scared of anesthesia, somebody is scared of the pain, somebody is scared of the preparation. So each one has different, and then that is one-to-one. And actually, the best way is that to ask them to go to their physicians and to see exactly what their concerns are, because there is an answer for each of those concerns. There are different preps. There are procedures that can be done without anesthesia, or if they have any questions, and also to that we discussed today, to tell them how if they know how much benefit you may get from detection of early stage cancer versus later stage, and how is the different in terms of the benefit they may get. So
It's
that might be
curable.
convincing conversation that they can have with their physicians, and different something that's totally curable versus something that is, if it's God forbid, is a metastasized disease or later stage disease, how devastating could be. That could be a way to encourage the patients to get to the test to get done.
And I'm just going to add a little something to that. Often women will talk to one another about what they have to do. And I know that I don't love the preps that I've had in the past, and I have to go and have them done regularly. So I focus on the positive aspects of it, which is the best sleep that you're ever going to have with the anesthesia that they give you, the sedation that they give you. So I sort of focus on that. But that was one of my first questions was about the prep, because it has historically not been great. But every time things get better, I sort of tell people that I love and that I know and that we're all trying to take care of one another, this is really better. And I think you just have to be kind of a nag at a certain point when you love someone and help them get over it, because really it can be cured. And that's why we're celebrating Colon Cancer Awareness Month at St. John's, but we celebrate it all year long because we like to take care of our employees, we like to take care of our community, we like to take care of each other. So, any other questions? No? Okay, well, I think that we're very done today. Thank you so much. You were a wonderful
very welcome.
guest.
Okay, thank you.
And thank you again to our audience online. Join us again for our next Riverside Talk.